Welcome to the Protecting Your Nest podcast. Before we begin today's episode, I want to remind you that I have partnered with QMed CME to offer continuing medical education via podcast. That continuing medical education would be in the form of CME, CE, and CEUs. And QMed CME is really doing a great job of filling the knowledge gaps in healthcare education through diversity, equity, and inclusion in medical education. So I'm really excited about that. And for me, it's just another way to help spread the metabolic health message to clinicians and anybody who's going to listen to this wonderful voice of healing. So if you know a clinician who you feel would benefit from learning the Protecting Your Nest podcast principles, just direct them to qmedcme.com, where you will earn continuing medical education virtually via podcasts and other formats. And yes, today's guest has agreed to join me for a future CME where we discuss how to effectively manage type 1 diabetes in the clinical setting. So let's get back to today's episode. You know, when I told my wife that today's episode was about type 1 diabetes, she was really excited because as a type 1 diabetic, she's always felt like she was a second-class citizen since type 1 diabetics never get the attention they deserve. So they're going to get some attention today, and I'm really excited that I have a guest who understands type 1 diabetes, has experienced it, and understands a better way to treat it. So when I told my wife, I said, if you were on this episode with us today, you know, what would you say? And her response was, why me? You know, now I understand as a pharmacist why some people end up with type 1 diabetes, but as an individual, you know, I thought I was doing everything right and I shouldn't have been diagnosed with this diagnosis. And she says she remembers the excitement of finding out that she was pregnant with our first child and finally making our anxious, you know, parents, grandparents. So we were really excited about that. But then later she found out that she was failing, at least that's what she thought, because she wasn't gaining enough weight during her pregnancy. As a result, she was told to eat more pasta, potatoes, rice, and other starchy foods. Unfortunately, that recommendation did not work well for her because she was told later that she had gestational diabetes. She said that her heart stopped only for a moment, but not for her or me, but for our unborn child and our future family. You know, what have I done is what she said. I did not, I thought I did everything right, she thought. And so she had a reality check, and they said, well, you need to go on a diet where you reduce, eat healthier foods, right? And she did exactly what she thought she should do because she really wasn't told what to do. And she started counting the number of grapes she was consuming, the number of chips she was eating. And that was her version of reducing the foods that can cause harm. And in other words, she just ate less of the wrong foods, you know. But after that beautiful baby, our first child, was born, thankfully for her, diabetes went away. So she was excited about that. But then came the second pregnancy, and yes, diabetes showed up again. And she had to go on insulin this time. And she said it was, again, a moment when the education about what to do was very low. So she did exactly what she was told. They just said, take the insulin you need for the food you eat. There was no direction about not eating this or not eating that. It was just take the insulin and make up the difference. And she got through that pregnancy. And thankfully, after that pregnancy, no diabetes. But unfortunately, she converted to being a diabetic maybe 10 years or so later. And it kind of broke her heart. And she said, oh my God, now I have to live with all the limitations of being a diabetic, taking insulin, not eating what I want, etc. So that was a very difficult moment for her. And again, that's why I was happy to learn of our guest. And our guest today is Dr. Keith Runyan. And I'm happy about him joining us today because he understands what my wife went through. And hopefully he'll share a little bit of his journey as well. He's a nephrologist, obesity doc. He has emergency medicine experience. And yes, he was diagnosed with type 1 diabetes, just like my wife. He has a blog at ketogenic-diabetic-athlete.wordpress.com. And his interest is in helping those struggling with diabetes and weight management. And of course, he uses a ketogenic lifestyle to help patients, clients, family achieve their blood glucose control. And of course, the type of body that they want. And he's also an online coach, diabetic coach. So we're really excited to have him because he has a lot of experience in type 1 diabetes, over 20 years. He was an athlete. He even competed in Olympic weightlifting. So, and of course, he's authored a book that we have. I should have it right next to me, but it's in my other room. And it's called the ketogenic diet for type 1 diabetics. So with that, Doc, I really appreciate you and welcome you to the Protecting Your Nest podcast.
Thank you, Tony. It's really nice to be with you today.
Absolutely. I was intrigued by the fact that you're focused on the type of diabetes that many people are not focused on because of the numbers. And I really am excited for anybody listening because we're trying to restore hope. And I just think that it's important. Now, what's really interesting as a metabolic health doc, you think I would have mastered how to help a type 1 diabetic, right? And I do find that it's more challenging. So I'm really excited for my wife and for myself to kind of, fill any knowledge gaps that we may have so we can achieve the type of success you've achieved. So before we talk about your personal story, I think it's important that anybody watching or listening understands the difference between type 1 and type 2 diabetes. So if you could briefly just give us a sense of that difference, that would be very helpful.
Okay. Well, type 2 diabetes represents about 90 to 95% of the type of diabetes that most people have. And so type 1 accounts for only about 5 to 10%. And so it is much less common, and therefore a lot of people, as well as doctors, know less about it. But type 2 diabetes usually begins with insulin resistance, meaning that their body doesn't respond as normally it would to insulin, which is a hormone produced in the pancreas by the beta cells. And this insulin resistance leads to or causes the beta cells in the pancreas to secrete more insulin. And this additional insulin then leads to additional storage of fat in fat cells. This in turn increases the appetite, and it sets them on a long road of weight gain. Usually, not every case, but the majority of people with type 2 diabetes have extra weight on their body. But and then over time, the insulin resistance worsens. Their liver begins to produce glucose that it really doesn't need to. And eventually, the beta cells get somewhat worn out and can't keep up with the amount of insulin resistance, even though they're producing more insulin than would normally occur. And this is when the blood glucose begins to rise, and that's when the diagnosis of prediabetes is made. And then, in our profession, we kind of come up with an arbitrary cutoff between prediabetes and type 2 diabetes. So if the fasting blood sugar is over 126 milligrams per deciliter, we then call that type 2 diabetes. But the whole process is the same, and there really is no important difference between prediabetes and type 2 diabetes. So, but in contrast to that, type 1 diabetes is actually an autoimmune disease where, we don't know exactly what sets it off. There's probably more than one thing. So a number of viruses, viral infections have been linked to type 1 diabetes. And also some dietary factors like gluten Some protein in cow's milk has been linked to it, as well as vitamin D deficiency in infants. So, but whatever the precipitating cause, basically the immune system in error recognizes that the beta cells in the pancreas, as well as insulin, are a foreign body, and that the immune system needs to destroy the insulin and the insulin producing cells. And that's what happens. Now, it can occur very rapidly, as in very young children, or it can occur over many years. And I think that's what happened in my case and probably in your wife's case. And that's given a slightly different name of latent autoimmune diabetes in adults. But regardless, it's the same process, even though they occur at different rates. So once the amount of insulin that can be produced gets to a relatively low level, let's say 70% or of what they, I'm sorry, uh, down to about 30% of the normal level, then the glucose rises significantly, and the person's diagnosed with type 1 diabetes. And so, since insulin is a building anabolic hormone, patients with type 1 diabetes will typically lose weight. Um,
Mm-hmm.
and they'll be kind of different in that regard from someone with type 2 diabetes. So they lose weight and then they develop other symptoms like thirst and urination. That's due to the glucose that gets spilled out into the urine. Um, and that's also partly why they lose weight, because they're spilling calories out into the urine in the form of glucose. But anyway, that's that. And persons with type 1 therefore must replace the insulin that the beta cells aren't making anymore with exogenous injected insulin, usually, and there is an inhaled form, but most are on some injected form of insulin. And so, we're very fortunate to have that, because otherwise, a person with type 1 diabetes would eventually die if they were not able to have those insulin injections. But what many people don't realize is that the injected insulin, although life saving, does not exactly replicate what the beta cells are able to do in terms of secreting insulin in response to a number of different things, in response to exactly what we're eating, in response to our insulin needs based on how much activity we've had, or based on stressful situations. And so there are many factors that make managing type 1 diabetes with insulin quite difficult.
Yeah, you're preaching to the choir with that, because I think when I suggested that even a metabolic health doc may struggle, and that's because of what you just said. There's so many factors beyond low carb, keto, or carnivore that are playing a role in our success as clinicians or people who are patients who deal with this. And that's the challenge, is that you can't just think about diet. So I think that's the thing. So we have to figure out how to, and that's why I have a nest and a rope acronym, right? Because I try to use that to remind myself and my patients that your success is more than just your diet. And if you only address your diet, now for some people that'll work, but for many, they need to address those other factors. So I think that's well stated. And I think for my wife, when we discovered it, it was similar in that it was a weight loss issue that didn't really make sense. And then that kind of led to other symptoms and things that we identify. So that's really helpful. So let's talk a little bit about your journey. And again, man, it's when something like that sneaks up on you, it really catches you off guard. It certainly caught us off guard. So When you think about your journey, how did it get introduced into your life?
Yeah. Well, first of all, I will tell you that 85% of people who develop type 1 diabetes have nobody in their family with diabetes. And so they call that sporadic or spontaneous type 1 diabetes. So that was my case. So I was when I started actually losing weight 2 years before I had the diagnosis. And I was definitely in a state of denial, which I'm sure you've seen with your patients.
Yeah.
When I was a young doctor, I would say, "How come you waited so long to come see us?" But that was because I was young and I didn't even understand that there was such a thing as denial. But
Right.
I was in denial really badly. So I lost weight for 9 months with not being concerned about it because I felt otherwise okay. Then I started having diarrhea, and
Hmm.
it was occasional at first, so I didn't think much of it. And then just very gradually over time, it was more and more often, continuing to lose weight. But I was also never in the habit of weighing myself. I had never been overweight, and so weight was never an issue for me. Then, about 3 months short of the diagnosis, or before the diagnosis, I started having more typical symptoms of thirst, increasing urination, uh, and so I finally, really kind of started feeling fatigued too. And I think that's the final thing that took me to go see a doctor. And
Hmm.
so I presented myself to a gastroenterologist because of the diarrhea. And so he did a large panel of tests. But of course, you always do a metabolic panel. And so my blood sugar came back 389 milligrams per deciliter.
Wow.
And interestingly, though, the celiac disease antibodies came back positive too. So he kind of thought that I had celiac disease and
Hmm.
as the cause of the diarrhea. Well, time passed, and I eventually got a small bowel biopsy, which did not confirm celiac disease. But I think the antibodies were probably correct because gluten intolerance is one of the potential causes of type 1 diabetes.
Yeah.
So I think that kind of fit with me. But anyway, the diarrhea itself, though, was more likely well, not terribly uncommon, but only about 20% of people with diabetes develop this diarrhea problem that I had. And it's called diabetic diarrhea. And it's actually an autonomic neuropathy of the intestine due to the fact that I had delayed my diagnosis such a long time.
Hmm.
I had, long-term complications of hyperglycemia because of my bad behavior of not going to see a doctor.
Hmm. And they always
Anyway,
tell us it takes 10 years for that to happen, right? They say it's going to take at least 10 years before you have a complication. You're saying, and
yeah.
if it was 10 years, that's insane, but maybe
Well,
not, maybe not.
so if I was losing weight for 2 years, let's just sort of hypothesize that maybe my blood sugars were elevated for 4 or 5 years. So, I guess it was long enough because I
Yeah,
certainly had that. Anyway,
that's
that eventually went away, but it did take 2.5 years of very of the best blood sugar control that I could achieve for that to finally stop. And but anyway, that was kind of my presentation. And of course, once I got that result back, I was kind of it was a combination of shock and depression
hmm.
uh, because as a nephrologist, I was very aware of all the complications of diabetes. The
Mm,
majority of a nephrologist patients actually have diabetes, and we're
hmm.
treating diabetic nephropathy, which is the number one cause of chronic kidney disease, as well as renal failure requiring dialysis and transplantation. So, here I am. I've got the same disease that I'm, having to deal with these major complications as my career. So,
Yeah.
it was not a bright light in my life at that time.
No.
Mm.
As you talk, I think about some of the training I've gotten in nutrition and functional medicine. And what I've noticed in the functional medicine component, there's always this perspective that's more narrow. So if there's, you have celiac disease, but you have gluten intolerance and there's levels to this, right? So the question is if you have the actual diagnosis and you meet the criteria versus you just have irritation and intolerance, is the intolerance still going to cause harm? And one of the things I've learned in that training is a lot of the autoimmune conditions that we have come from our gut being damaged by what we eat. And so if gluten's something my body doesn't tolerate, which is true of a lot of people, then is it possible that that led to a leaky gut or some irritation that then led to the absorption of some proteins that rather is a casein from milk or some gluten, did that then lead to your body saying, I don't like that, I'm going to attack that, and then you all of a sudden end up with an autoimmune disease because maybe those things look like the islet cells in your pancreas? So it's just interesting. What I like about the training is that it just forces you to think about these things when historically I would have gone down that rabbit hole of, let's treat your symptoms, or, we're not even going to think outside the box at all. And I just think that it's important that we open our brains to different ways of looking at things. So, but when I think about your journey, also, and I think about my wife's journey, it was pretty devastating. And you're a highly trained professional. She's a pharmacist, and it hits you out of nowhere. So, from an emotional perspective, what kind of impact did it have on you?
Well, I think it was about a year-long process of basically being down about the whole situation. Uh, because the other part that made me feel down was we are taught in medical school and through our residency training several principles that I think are not quite right. And one of them you mentioned, this idea of leaky gut was never mentioned in medical school or in
Never,
residency training. Um,
never.
uh, and I think that's a real source of most of the autoimmune diseases, if not all of them. Um, and there are a lot of autoimmune diseases that clinicians take care of, on a daily basis. So that's very, very important. The other thing is that we are taught that type 1 or anybody with diabetes for that matter should keep their hemoglobin A1C around 7%. Well, normal is around 5 or a little less than 5%. Now, why is that all diabetics should be kept at a high blood sugar? It's the high blood sugars that lead to the complications of diabetes. Why is that our goal? Well, the reason that's our goal is because if you consume the diet that is recommended to patients with diabetes, you cannot have normal blood sugars without multiple episodes of hypoglycemia. It's
Right.
just the way it works. So, uh, so now for that first year, I'm saying, well, how am I going to get out of this situation? I can't have normal blood sugars. And I was having hypoglycemic episodes. So I'm experiencing what I was taught happens is that, you can't have normal blood sugars without having hypoglycemia. And so therefore I'm looking at, well, I'm going to be developing one or more of these complications in the future. And that's what
Hmm.
was depressing about it, despite my best efforts.
Wow,
So,
it's very depressing, and I think us understanding um, the psychological impact is important. We need to understand that this less tight control is a problem, and we need to ratify that. And you can't, if you try to do it with medicine, it's difficult. And while you're chasing this, you got this poor diet that's going to raise your sugar. You're chasing it with medicine. It's just a roller coaster,
yeah,
and I
I
don't
would
think
say
any.
it's more. I would say it's more than difficult, Tony. I would say it's
Yeah,
impossible.
yeah. I that resonates with me, and again, that's why my wife was happy to know that somebody's out here trying to deal with this because low sugars. I mean, when I was doing some research on hypoglycemia in my health system, we did learn that first of all, doctors not asking people about hypoglycemia. It becomes par for the course. So patients think is what you live with. The doctors think is what you live with, and it's not really being asked about or addressed. And so and then we learned things like it can increase your risk for cognitive decline over time if you keep having these low blood sugar episodes. And that was eye opening. Another thing that was interesting when it comes to relationships, that person that's having that experience they may struggle. In fact, I can't remember if it was a scientific study, but there was some evidence that when people experience this a lot, they tend to have uh, you know more problems in their relationship than if they don't experience this. So it's like all of these downstream effects that people don't think about, the doctor's not thinking about, and we have to understand this is part of what we need to solve. That's why this lackluster control is not a great idea. So um,
Yeah.
so in other
Well,
words,
the points you just made kind of go back to what you said at the very beginning about the
yeah,
fact that type 1 diabetics feel alone. That's
yes.
because, their doctors really don't understand what it's like to live with type
No,
1 diabetes. And the patient feels alone because their doctor doesn't even understand what they're going through.
that's
And
right. They
so,
just don't.
these hypoglycemic episodes are not only potentially fatal, they not only can cause serious problems like seizures, car wrecks, things like that, but when you're more aware of having it, but you're out in public, it's
Mm,
embarrassing because
yeah,
you can't think quite straight. You may say something you didn't mean to say. You're sweating profusely, and people are looking at you like, "What's wrong with you?" Because when you just look a person with diabetes, when you just look at them, they look normal. But
right.
now here's this normal person just sweating profusely and looking strange and kind of staring off in space. So the whole situation is embarrassing. And then sometimes it happens at work, and if your coworkers don't know that you have type 1 diabetes, then it's bad. I'll
Yeah,
tell you
yeah.
just a personal story is I had in my office I had just hired a new receptionist, and it was her first day on the job, and I just didn't think about telling her I have type 1 diabetes. And
Mm,
that particular day, I was in with a patient, and I started sweating. Patient
mm,
didn't know I had type 1 diabetes. So
mm.
the patient got up, walked out of the room, told the receptionist. She calls 911. The next thing I know, paramedics are walking into uh, uh, my exam room, and I'm saying, "Oh, I must be hypoglycemic."
Mhm.
So I pulled the glucose out of my pocket, and I said, I got this, guys. Uh, it's just nobody said anything to me. There was no communication. So, I took my glucose tablets. That we waited 15, 20 minutes. They checked my blood sugar. I was fine. But, that affects you,
Hmm.
because you always, that can happen anytime.
Right.
And without warning. So, and that's
Yeah.
part of the hypoglycemia is because it affects your mind right at the same time as everything else. That's why a person with type 1 is not always aware that they're having hypoglycemia.
Right. Right.
Yeah.
In fact, the continuous glucose monitor was a gift because that's when we were able to. There are
Yeah.
many times when it's happening. You don't. I mean, it's nice because it warns you, but it's like you don't see it right away, and but you can't be feeling your best when that's happening. You can't be
Right.
mentally clear when that's happening. Your brain needs fuel, so it's again, it's something that you you don't fully understand until you're either experiencing it yourself or you have somebody that's close to you that experiences. But
Right.
I would argue nobody understands this more than a patient who's going
Exactly.
through it. So now
Exactly.
you're a nephrologist, right? And it always tickles me when I see, like, I interviewed Dr. Anthony Chafee, who was he's in his neurosurgical residency, right?
Hmm.
And it's funny in that you don't expect to see a neurosurgical resident dealing with metabolic health and the things we talk about, right? But
Yeah.
but so, as a nephrologist, you've had a chance to think about, the kidneys and keto, and I know we're going to do a continuing medical education for our doctors, but that word keto scares everybody, even though it's better than it used to be.
Yeah.
So any comments about um, the keto diet as it relates to um, protecting your kidneys so that they're not being harmed by that?
Right. Well, I think that again, it comes to lack of our medical education. So,
Hmm.
really, the only time that word keto ever came up in medical school was in reference to diabetic ketoacidosis.
Pretty
And so,
much.
that's what doctors' minds go to when they hear keto. So, what I'm doing and what I'm advocating for people who want to improve their blood sugars is called nutritional ketosis, not ketoacidosis. And they're two totally separate things. And all nutritional ketosis means is that we're eating so few carbohydrates because carbohydrates are a non essential nutrient. We can live just fine with no carbohydrates for our entire life. And I don't eat zero, but I'm eating about 30 grams of carbohydrate a day. But when we do that though, the body says, our brain needs a little bit extra fuel besides just glucose. And so it takes fat molecules called fatty acids and converts them to ketones, just as a source of fuel for the brain and other tissues. Like the heart is very good at using ketones, and a number of tissues are, but the brain is the one that really needs that extra fuel in the form of ketones. The brain actually will utilize those ketones in preference to glucose, but it can't go without glucose. So even when you are on a ketogenic diet, you don't want to have hypoglycemia because the brain needs glucose too. But it's not something that anybody needs to be concerned about having these ketones. It's just simply an additional source of fuel for the brain and other organs. And it's a natural consequence. People without diabetes, if they restrict their carbohydrates, they'll be making ketones too. So it's not anything unique to diabetes. But the reason that uh, carbohydrates restriction in the diet is an advantage for anybody with diabetes, type 1 or 2, is because carbohydrates actually require more insulin to dispose of them. In other words, to put when carbohydrates are metabolized, they're metabolized to glucose. That glucose can't stay in the bloodstream. It needs to be put somewhere. It needs to be put in the liver as glycogen, or in the muscles as glycogen, uh, or converted to fat and put in fat cells. But that requires insulin. So disposing of that glucose from that dietary carbohydrate requires more insulin than it does to dispose of protein, and even more than disposing of fat. So just to give you a relative amount, it takes about twice as much insulin to store carbohydrates as it does protein. And it takes about 7 times as much insulin to store carbohydrate as fat. So by minimizing the amount of carbohydrate a person with diabetes consumes, we can reduce the amount of insulin they need to normalize their blood sugar. And that's the whole basis for this low carbohydrate diet for diabetes, is how do we use less insulin? So for the person with type 2 diabetes, requiring less insulin helps them to resolve their overweight, helps them to resolve their insulin resistance. And in persons with type 1 diabetes, minimizing that insulin dose reduces the chance that they'll have hypoglycemia. And then it's true that about half of persons with type 1 diabetes actually have insulin resistance and are overweight. So
Yeah.
it's called double diabetes. And so they get the double advantage of carbohydrate restriction for type 1 diabetes if they have double diabetes. So that's kind of the idea behind it, and it turns out that in practice, it works very well.
It makes a lot of sense. I am still perplexed, and I shouldn't be too perplexed because we're kind of, we're kind of on one hand taught to think uh, independently, be skeptical, and never judge a book by its cover. We're kind of told that, but then when we leave our training, we are asked to just follow the rules and do
Yes,
what the rules say, rather it's the
yeah.
dietary guidelines or whatever, right?
I
But
think you're very perceptive because most doctors don't realize that. Medicine is very dogmatic. And I remember I used to try to challenge things, and boy, I was cut down very quickly, and I stopped.
yeah,
Because
yeah,
again, when a professor of medicine cuts you down for asking a question, why is it we're doing it like this? And then they cut you down and say, you just don't want to experience that again. So,
mm-mm.
you just stop and you just, okay, well, I'll just accept what they say and
Well, I
go
had to
on.
be
Go on.
older. I definitely had to be older. So my nutrition and functional medicine training is just being completed now. And I went into that program having had some experience with other approaches, mostly in the carb restriction space. So I could have a conversation with the professor that wasn't intimidating like it was when I was a medical student.
Hmm.
And and because I was able to open my brain when I would hear, so when I learned a very simple approach, which is you have something that causes harm, you can even call it a poison if it's excessive. So carbs are not harmful, but excessive carbs certainly can be, and we can talk about plants and anti-nutrients in another podcast. But in terms of too much carbs, then you'll need an antidote, which is the insulin or the medicine, right? And all we're asking people to do is either work on both ends of those spectrum, or at least understand that if you don't have the poison, you won't need the antidote. And it's really simple, but our medical, as community is still focused on antidotes, and there's many reasons for that. But I just think, as a healer, it makes more sense to understand what's the cause, and let's go to the root cause first, as opposed to trying to, for lack of better words, put a Band-Aid over the cause, which will never really resolve the problem. So thankfully, we're able to think outside the box, and we need more people like yourself who are also thinking outside the box. So now some people came to this episode for one reason, which is, what do I need to do differently as a person? They'll probably buy your book, and they'll probably, dive deep there. They may even find a metabolically trained doc to help them. But what, just give some of the tips that you shared in your book and in your life that helps a type 1 diabetic get closer. Because when I did my research for you, I saw that you achieved A1Cs in the 5 to 6 range. In other words, in the normal range, which is, I don't know if that's unheard of for type 1s, but you don't see that every day. So what kind of things that you have to do to achieve that?
Yeah. Well, actually, I started this low carb ketogenic diet in 2012. So ever since 2012, my hemoglobin A1C has been 5.1. It hasn't been higher than that.
Amazing.
Now, what has changed over the time since 2012 is from 2012 to 2019, I was still having occasional hypoglycemic episodes. And I was kind of fed up with having them, to the point that I said, there's got to be something else I can do. And so that's when I, started looking at these other things that we mentioned earlier in the podcast about, the effect of exercise on our blood sugars, the effect of stress on our blood sugars, the effect of sleep on our blood sugars. And so those are things I got more control of and became more consistent with in 2019. And that's when I was able to reduce the variability of my blood sugars to the point that I was no longer having these hypoglycemic episodes. So for the last 3 years, I've had an average blood sugar about 100 milligrams per deciliter, and a standard deviation of about 18 milligrams per deciliter. Standard deviation is a commonly used statistical measure of variability. And that number can be given to you on most of the blood glucose meters, as well as all of the continuous glucose monitors. They will give you that number,
Yeah.
so you can monitor where you are. But that is crucial, because if you have a high variability, then you shouldn't be seeking flat out normal blood sugars, or
Mm-hmm.
else you'll be having hypoglycemic episodes.
Right.
So that's so you said in terms of tips. Well, the number one tip really is this low carbohydrate diet. That's probably the biggest factor. Because as I mentioned earlier, those carbohydrates require larger doses of insulin. So if you have a 10% error in your dosage that you choose for a meal, uh, but that dosage is 5 units of insulin, you're going to have a bigger potential error than if your dose is 1.5 units, which is
Right.
kind of a typical dose that I might give. So uh, that is why low carbohydrate diet has such a dramatic effect on both hypoglycemia, uh, glucose variability, and the average blood sugar. So that's the first step. And that's what with my clients that I coach, you know, we try to do just one thing at a time. I don't want to
Mhm.
overwhelm somebody with 10
Mhm.
different things that they need to do. So that's the first thing, is to implement a low carbohydrate diet. It can be done gradually. You can just
Mhm.
start with the diet you're on now and just gradually reduce the amount of carbohydrates and gradually increase the amount of fat in the diet. Um, or it can be done all at once. So I kind of did it in phases. Um, and that's because I had found the paleo diet before I found the ketogenic diet.
Mhm.
But either way would work. The only caution would, for somebody, if they're going to do it all at once, is that they really need to talk with their doctor about their medications for
Mhm.
diabetes, as well as their blood pressure medications if they're on any, because they may need to be reduced rapidly.
Yeah,
Uh, and I figure there's probably going to be some people with type 2 listening, and so they
that's right.
especially are going to need to know
That's
that
right.
they're going to need. And there's a class of diabetes medications called sulfonylureas, which cause the pancreas to secrete insulin. And if those are not stopped early on when starting a ketogenic diet, there can be hypoglycemia that's dangerous, as well
Mhm.
as SGLT2 inhibitors. Those are very potent medicines at causing urine to leave the bloodstream and appear in the urine. And those also should be reduced or stopped depending on what your doctor recommends when starting a low carb diet. So I just wanted to throw that caution out. And then, some people's blood pressure drops precipitously because one of the causes of high blood pressure is this insulin resistance and high insulin levels.
Mhm.
And if you suddenly improve on it by restricting these carbohydrates, you can have a pretty dramatic reduction in blood pressure. And if you're taking blood pressure medicines, you could possibly pass out as a result of the diet. So important to have your doctor involved if you're going to start it all of a sudden. But anyway, uh, so that's the biggest tip. And then the other part is exercise has a big influence on blood sugars in persons with type 1 diabetes, even more so than those with type 2. So it's hard to give out general rules, but I'll go ahead
Mhm.
and make an attempt that generally endurance type exercise, like you go for a jog or you go for a run or you go for a long bike ride, in general, most people's blood sugar will gradually fall during that activity. And
Right.
if you do it for long enough without taking some sort of snack or something along the way, they'll end up with a low blood sugar. And that's kind of discouraging because you're trying to be out there being healthy and you know doing your body good, and then you wind up with hypoglycemia. So
Right.
so in my book, Master Type 1 Diabetes, uh, I go into a lot of more details than in the previous book I think that your wife read,
Yeah.
about how to deal with that. So,
Mm.
there's basically reducing the insulin doses prior to that type of exercise, or taking glucose tablets or some other glucose supplement with you. And that's where the CGMs come in handy. You can
Right.
monitor that while you're exercising and supplement along the way. Um, but there's other activities like sprinting or very intense type of exercise that can cause the blood sugar to go up quite dramatically. And in fact, I found a paper where they had, I think it was about 8 athletes who were doing intense exercise, and they were non-diabetic, and their blood sugars were up in the 200s. You
Wow.
know, and now,
Yeah,
did they come back down to normal within 3 or 4 hours? Yes, because they have a working pancreas. But
that's right.
a person with type 1 would need to dose. insulin after that type of activity to bring that blood sugar back down. Now, I do intense exercise. That's called Olympic weightlifting, is what I do. But by scheduling it at a certain time of day and then adjusting the dose of insulin that I take prior to Olympic weightlifting, I can actually prevent the rise in blood sugar. So there's a lot of strategies relating to dealing with all types of exercise in my book, Master Type 1 Diabetes, which is on Amazon. Um,
Yeah, that's helpful.
yeah. So just a quick reference about the sleep is, some nights you got a lot of stuff on your mind. You may not sleep well. Well, if you lose several hours of sleep, the next day you're going to be relatively insulin resistant. And then therefore, you're injecting insulin, it's not going to have the same effect. And so you're going to end up with high blood sugars. And you're going, well, what's this all about? Well, it turns out that sleep is definitely one potential cause for having high blood sugars. Um, so sleep is something that just, is part of the education process. So I'm trying to understand why things are the way they are. It's always helpful to know why so that you can know what to do about it. But and then stress is another one. For instance, I'm not saying I will, but it's possible that after this interview, if I go check my blood sugar, it might be elevated.
Hmm.
Just because doing a presentation or doing some sort of performance, so to speak, or let's say a
Right.
student has a test on a certain day. They go take the test, and after the test, they find their blood sugar's high. Well, taking a test is potentially a stressful event. So, you know, that has a definite effect on blood sugars.
Wow. It's almost like, and I can see why my wife was upset when she got diagnosed because she wanted to have a body that was on autopilot. But if you don't, it can't be on autopilot if all the pilots are not doing their job. There's things missing. So now you
Yeah,
have to,
unfortunately, Tony, there's no such thing as autopilot type 1 diabetes.
right?
There's no such
I,
thing.
yeah, no
You got
such
to
thing.
tinker with it every day.
Yeah, you're tinkering. I think that's the biggest loss I think she had because the tinkering takes energy, right?
Yes.
So, but I agree with you. You want to tinker with some good resources like your book, a clinician who gets it, and then you have to. And everybody's different, so how one person's body responds is different. I will say that the Society of Metabolic Health Practitioners, Low Carb USA, do have the guidelines for therapeutic carb restriction that were created by Adele Hyde and others. So if you're listening to this episode or watching, and you're like, man, I want to do this, but I want my doc to, understand how to do it safely. In those documents, it'll suggest how much you should reduce the insulin. It'll suggest things like that. So a clinician who hasn't done that will have a little something in front of them that we can use. And you're right. It doesn't surprise me at all. Going back to the stress part is, yeah, I mean, if you don't get sleep, that's stressful. If you're under stress, that's stress. Of course, the stress hormones will kick in, and I can see that easily raising your blood sugar. So it's a lot of things to keep in mind. There's no magic pill here. It sounds like you have to monitor, understand what your body's doing, and then adjust, correct, and adjust. So that's very helpful.
That's
Um,
right.
any thoughts? I know we're going to do a CME for the doctors, but just in terms of the dietary guidelines, because we're kind of married to the guidelines, some of us have the courage to not be married to the guidelines, and thankfully, large organizations are now saying keto, low carb is okay. It's an option now. But anything that you would say to a patient or a clinician who may not, they may be still married to the old guidelines and food pyramids that never served us. Any advice you would give them?
Well, I think I would inform them that the guidelines actually are not science based. They're not evidence based guidelines. They are based on a lot of opinion, a lot of epidemiology studies. Um, and when you really, there are some very good people in the low carb space who have, like Zoe Harcum, who have actually researched what is the basis for our dietary guidelines. And basically, the rationale was a wrong hypothesis about dietary fat causing heart disease. And so the idea was, well, that's simple. Let's just reduce the amount of fat we're eating. Well, what they forgot was now you're automatically telling people to increase the amount of carbohydrate they're eating.
Right.
And they did not research what the effect of doing that would be.
Hmm.
So what people need to know is that the current dietary guidelines are based on a hypothesis that has never been proven to be correct or never been shown to be correct with evidence, and it's not working. We have an epidemic, pandemic of obesity, type 2 diabetes, and a host of other metabolic diseases. Heart disease is a metabolic disease. Cancer is a metabolic disease. And so they have to recognize that these dietary guidelines are not working. So let's think out of the box and let's think about, especially with diabetes, I think it's a no brainer that dietary carbohydrates, I think you were said it earlier, our dietary carbohydrates are basically a toxin to someone who has diabetes.
Right.
So let's get rid of the toxin and eat a healthy, high fat, adequate protein diet, restricted in carbohydrates, and we will not adversely affect our health at all. In fact, will improve our health, will improve our blood sugars, will reduce the likelihood of hypoglycemia, and reduce the severity of hypoglycemia. So that's my tip about the guidelines is they just aren't correct.
Just not correct. I agree. And, when I speak at the Symposium for Metabolic Health, which will be the week before this episode will be released on August 25th through the 28th, I will see Gary Taubes and Nina Teicholz there as well. And thankfully, those journalists were able to help us piece through some of the noise and find out that the science wasn't really there. And I know Nina Teicholz with the nutrition. I think it's the Nutrition Coalition.
Right.
She's able to help us, put the pressure on our guideline writers and the government. We have to have evidence based. If we're gonna have guidelines, she prefer we don't even have them. But if we're gonna have them, they need to be evidence based. So thank you so much for that. I do want to ask you because we want to keep you healthy and around. You're certainly doing a great job. Any other areas that you're going to focus on personally as it relates to my nest and rope that maybe you're going to target yourself personally so you can kind of keep walking towards improved health?
Yeah. Well, as I told you, the tinkering part with type 1 diabetes never ends. So I'm always striving to reduce the variability of my blood sugars even below 18. I've gotten as low as 17 for the month. And just by the way, I post all of my blood sugar results on my blog. That's one of the main purposes of my blog. So people can just see what is possible when you really are trying hard to have normal blood sugars. Uh, but, I would like it to be 16, 15. I mean, you can't have a too low of a glycemic variability number. So,
Right.
yeah, if I could just improve on that, that would be great. Uh, the other thing is I'm trying to get stronger. So, normal thing when people age, I'm 62 now. Normally, people from this point forward, they just get weaker and
Yeah.
weaker
Yeah.
and lose muscle mass. And, therefore they're susceptible to falling and breaking their hip. And, so I want to avoid all of that. So I'm lifting my weights, and I just want to keep getting stronger as much as I can. And, if I can't get stronger, well, how about just don't get any weaker from this point forward? So
That's
that's
right.
that's kind of what I'm working on myself.
That sounds smart. I have seen studies in my training that correlate muscle mass with longevity. And
Yeah.
so if you don't have muscle mass, you're really putting yourself in harm's way. So I think that's smart. And another person who will be at the Symposium for Metabolic Health will be Dr. Ben Bokikio, and he is big time on using resistance training. And you can do that rather with bands or gym equipment or a total gym very safely. And you don't have to do a lot of it. In fact, his theory is give yourself at least 2 days between full body workouts to recover, heal, and grow the muscle. So I take that approach as well. And I appreciate that. So now let's wrap up with you sharing, reminding us about your book, where it can be found, any other opportunities for coaching and outreach that you provide to the community.
Yeah, it's pretty simple. So I've got the blog, which is ketogenic diabetic athlete.wordpress.com. And on there is a link if anybody wants to connect with me about coaching. And then my book is called Master Type 1 Diabetes, the simple low cost method to normalize blood sugars. And that's on Amazon. I think it's pretty much most of the Amazon sites all around the world. It comes in a Kindle, a paperback, or a hardback cover book, and it's got all the my latest. I've been updating that book every year, so I updated it this year, and it's got all the latest strategies that I use and others have found successful to normalize blood sugars. But
Nice.
thank
Well,
you for asking.
yeah, and I think we have some work to do. So again, it's not a magic pill, but we now have some experience and some resources to help people who are struggling, who are frustrated, who are tired of hypoglycemic episodes, and who want to live a full life. So I really appreciate you, the work you're doing, and my wife will definitely be checking out this episode. So thanks for the
Okay.
opportunity, and appreciate you.
It was great talking to you.
Absolutely. So today, for those who are watching or listening, today we gave our friends, family, and if you're a clinician, patients, some hope if they have type 1 diabetes, and the hope that they can live a life without hypoglycemic attacks. And yes, even a person with type 1 diabetes can have a hemoglobin A1C in the normal range as low as 5.0, 5.1, which is a really great thing to hear. So he's given us with the doc's comments today, an opportunity to know that yes, we need medicine if we're type 1 diabetic, but we don't want to rely just on that to reach our goals. So thankfully, we have medicines. Without medicines, my wife and my friend, the doctor, would not be here without medicine when you're a type 1 diabetic. So I'm very excited that we have another way. So we need more experts in the world, like Dr. Runyan, who are managing type 1 diabetes effectively. And with this same approach, I think a type 2 diabetic can reverse their type 2 diabetes without a doubt. I see it in my practice every single day. So if you're interested in learning more, please, check out his book. I have a link tree with a 2-page handout So check out the show notes for my link tree. It gives you at least some ideas of how to get started on low carb. And I just really appreciate each and every one of you just for taking the time to check us out, because these are the moments, these are the nuggets that can make a difference in your life and the lives of the people that you love. So I thank you again for being with me today for this episode of the Protecting Your Nest podcast. And as we wrap up, I ask that you continue to be safe, be well, and continue to protect your nest.